So the first point I'd like to make is that we are all here and we have been talking about continuum of care, and it is very important to keep in mind later on when we focus on misoprostol that yes, it is within the continuum of care. Misoprostol can be used mainly at the community level, and if you're wondering why the box goes up to the hospital and tertiary, I just wanted to include its use for treatment as well. So the title reads is for management, and there are other interventions like oxytocin in Uniject, and of course the gold standard oxytocin and EMONG. These are all continuum of care, and we just have to keep that in mind that they're not competing with each other, but we're trying to find the best solutions in terms of what works best in which condition. And the other point I'd like to make here is that Asia has been taking the lead in terms of community level use of misoprostol. Oops. Okay. So, so far there have been about 18 countries and counting where you can find some study, either a study, it could be randomized control trials, which are actually quite few at the community level, and more often reports from programs, implementation programs, and operation research that has shown that the community level use of misoprostol is effective, it's feasible, safe, and it's acceptable by women. Of those 18 countries that I was able to identify, 6 are here in Asia, Bangladesh, Afghanistan, Pakistan, Nepal, India, and Indonesia, and the 12 are from Africa. So I will be mainly focusing on Asia results, and I will also give some insights from what's going on in Africa in terms of community level use. One way to think about community level use of misoprostol is to think of it in terms of community-based distribution. And this, I think, helps us to frame it and also to think about, to learn from other community-based distribution programs such as family planning or prevention of from mother to child transmission, HIV transmission programs. So at the community level, when you want to make sure that you're addressing home deliveries, you want to make sure that the woman has a uterotonic that she can use at the time of the delivery. And the role of misoprostol in this, as we have talked about before, it can be at different levels. So, I mean, the way a woman can get misoprostol and then use it at home delivery can be done by different models, different community-based distribution models, if you want to call them that. So she can get it from a community health worker when she's still pregnant. She can get it in a clean delivery kit, again, when she's pregnant. Or she can go to, we know that many women go to ANC, even though facility deliveries are low. We know that it can go as high as 90%, so that's an opportunity for us to make sure that women will have this drug. Or sometimes she can get it through private sector. It could be pharmacies, or it could be programs which are using social marketing, or sometimes vouchers for antenatal care, and misoprostol could be in those vouchers. And then she can use it at home. Another time that she can get it is at the time of delivery. So again, at the time of delivery, she can get it through either a community health worker or a traditional birth attendant, auxiliary nurse midwife, or in Ethiopia, for example, through health extension workers. We have heard earlier this morning that the difference between giving the tablets to women at the time of delivery versus giving her ahead of time, advance provision of tablets, and we have heard WHO to be able to do more research into what happens when they're given in advance before delivery. This point should go without saying. We have also heard this morning that about the efficacy studies showing misoprostol. So these, but here they are anyway, and India, Pakistan, and Bangladesh, we have these results which show that the PPH rate has been decreased in women when they use misoprostol. Maybe one thing to point out for me here is that in India, auxiliary nurse midwives distributed misoprostol at the time of delivery. In Pakistan, it was traditional birth attendants. And in that study, it's also indicated that traditional birth attendants were able to administer misoprostol, collect blood, collect blood and measure blood loss, and also manage referrals very effectively. And in Bangladesh, it was the community health workers. I don't think there's any further need to do further efficacy studies, especially if you want to focus more on operational research. So I would like to first start with Bangladesh, which again has taken the lead in community level use. These are 3 operational research studies which are not published yet. They are available in the form of reports so far. And I am sure we're going to hear from the other presenters in more detail about Bangladesh. One thing I would like to emphasize here is if you look at the numbers, 77,000 women in one ICD-DRB study, and then 19,000 women in the first phase of another USAID and gender health study, and then another 19,000. And in all of these studies, a significant number of women delivered at home, and more than 90%, and in the 2 last studies, more than 95% of women used misoprostol. Feasibility is one indicator that is used in community level use, and does it really work? When we make misoprostol available, does it really reach women? So I think these are very important results that show that yes, it was feasible and it did reach women through these distribution mechanisms. Just as a side note, in Tanzania, for example, another study in Tanzania showed that 88% of home births were protected with misoprostol when it was distributed at ANC. Another indicator is program effectiveness. So it is the increase in uterotonic coverage. We have very good examples, again, from Nepal and Afghanistan. The Nepal one was before-after comparison, and Afghanistan was a control group versus intervention group. And you see the results here that uterotonic coverage has significantly increased. And uterotonic coverage, it is used to imply any uterotonic that was used at the 3rd stage of labor, so includes misoprostol and oxytocin. There are also some other interesting points that I'd like to make about these 2 studies. In Nepal, for example, at the time of the study, it is reported that institutional deliveries increased, and oxytocin use in facility deliveries also increased above national levels. So, of course, we cannot conclude that there was a causal relationship, but at least it gives some answers to the question, does it prevent women from delivering at facilities when it's used at the community level? Another thing that we have learned is that not only coverage is increased, but it reaches the women who need it the most. Namely, those are the poor women, the illiterate women, and those women who live the furthest away from health facilities. So based on these results, that women who lived in remote areas, like more than 3 hours from a health facility, the coverage among that group with community-based distribution was 9 times increase as opposed to 5 times increase in women who were living closer. And this is to show that community-level distribution is safe and acceptable. We can pretty much say, like looking at all of the operations research, that it has been safe in Asia and Africa, and it has been acceptable by women. But I'm using Afghanistan because it has a perfect track record of 100% women taking it correctly after birth. If you look at operations research from Africa, we have similar results, 90%, 95% of correct use, and correct use means using correct number of tablets at the correct time. So one question that keeps also coming up, do women understand the message? And yes, they do. We also know that. Here's a brochure from Pakistan, from social marketing. The name of the drug was called, in this case, ST-Mom, which means Save the Mom. So it's a program that women perceive as it is going to save mothers. And in Nepal, for example, the name used was Mother's Protection Tablets. I really like this picture, that it shows to me that community-level use has additional benefits for women and families. These are not always measurable, or we don't know yet how to measure them well. How do we measure that the woman is empowered and now she knows that she can prevent PPH, at least do something to prevent PPH that we know works? And how does this change the dynamics within the family? How does this change her family planning behavior, if at all? Those are, or maybe in the community, what happens to her when she's involved in such a program. Look at the gentleman there in this picture. He's kind of in the behind, probably in line with the cultural, norms here. But it's the men, the husband, the mother-in-law, and women, and they're making sure that they have the Misoprostol tablets in a locked place, and everybody knows about it. So when it's time for delivery, women may forget about it, but there will be other people, family around her, who will remember and who will bring it to her so she can take the tablets. Very quickly, I think it's time to talk more about scaling up of Misoprostol programs. And I took the liberty of putting some countries. And actually, the countries in this list I took them from the status report that have indicated that they are scaling up. So Bangladesh, Nepal, Afghanistan. Again, congratulations to Asia. And we also have Nigeria, Ethiopia, and Tanzania, who, based on the survey results, said that they were scaling up. There are also other countries who have a lot of momentum, like Ghana, Kenya, Tanzania, and Mozambique, who have completed their operations research. And they're just, they have decided they want to scale up, but they haven't yet. And then there are a few countries like Rwanda, Zimbabwe, South Sudan, where current plans for scale up is going on. One thing to mention is that there's a lot of background work has been done. Misoprostol has been registered in these countries.
You probably have about 1 minute left.
1 minute, okay. And there's international policy, WHO, FIGO, ICM, ECOG behind this. There are issues to consider for nationwide expansion. They're similar to what we have discussed. Quality of drugs and lessons learned. I will skip this in the interest of time, but I'm happy to discuss further. Because we have to remember the potential impact that misoprostol and oxytocin can make, and they could, together, when they're used together, they could prevent 41 million PPH cases and save 1.4 million lives, and I think that's a motivating idea. And my last slide is based on the report, Countdown 2015 Maternal Health Report. Skilled birth attendant coverage was the least equitable intervention, and community-based interventions were more equally distributed than those delivered in health facilities. So misoprostol use at the community level is an important tool to address inequity and to reach Millennium Development Goal number 5. Thank you.